Hi, everyone. It's 12 on the dot here on the West Coast, so we're going to go ahead and get started. Thank you so much for joining the second session in our age-friendly geriatrics education Tele-ECHO series on chronic diseases in older adults. The series has been organized for you by the UC Irvine Division of Geriatric Medicine and Gerontology and our Geriatric Workforce Enhancement Program. Again, thanks so much for taking time out of your day today, and happy Friday. We have a lot to get through, so let's go ahead and get started. This is the structure of our ECHO series, as you may know if you joined us last or 2 weeks ago. So we're going to go ahead and get started with introductions and announcements, moving on into our didactic on blood pressure and lipid management. And then we're going to have a great case discussion and then quick closing and reminders for the day. To make sure the session runs smoothly, you have been muted upon entry. So if you do wish to speak, feel free to unmute yourself at any time. Introduce yourself with your name and location prior to speaking, and always maintain confidentiality when speaking about your clients by refraining from including any identifying information. This is an hour-long session and is approved by the ACCME for 1 CME credit. So make sure that you do fill out the surveys that are sent to you after each session to receive CME credits. And if you do attend all the sessions in the whole series, you will receive 6 CME credits total. Our series is a part of the HRSA Geriatric Workforce Enhancement Grant at UC Irvine, and one of our main goals for our grant is to train geriatric specialists, primary care providers, and health professions, trainees, and to help expand geriatric workforce. So you all are definitely a part of this geriatric workforce, and we truly thank you for all the work that you do, especially through this trying year. So thank you for being here today. Let's go ahead and move on into our introductions. If you are here and joining us today on the line, please go ahead and introduce yourself via the chat function. We'd love to see where you're joining us from. Please include your name, your role, your site, and your location, please. And we'll go ahead and have our hub team introduce themselves on video so you can get to know us. My name is Nika Seville, and I am the project manager for our Geriatric Workforce Enhancement Program, and I'm joining you from Orange County, California at UC Irvine Health. 2 of our hub team members are out today, but let's have who's on the line introduce themselves. Dr. Sagal.
Hi, everybody. Welcome. I'm Sonia Sagal. I'm a geriatrician at UC Irvine, and it's my pleasure to welcome you today.
Thank you.
Everyone,
I'm
thank you. I'm Sarah Campbell. I'm a family nurse practitioner at UC Irvine and assistant professor in the School of Nursing at UCI.
Thank you. And our guest hub team member and presenter today is Dr. Matthew Hakimi. Can you introduce yourself?
Yes, thank you. I'm Matthew Hakimi. I'm a cardiology fellow here at UC Irvine, and I have a personal interest and some professional background in hypertension and lipid management. I'll be presenting the talk today. I'm very happy to join you. Thank you.
Thank you, Dr. Hakimi, and Carlos.
Happy Friday, everyone. My name is Carlos Garcia, and I'm the data analyst for our Geriatric Workforce Enhancement Program here at UC Irvine Health. Welcome.
Thank you to our hub. I see people from Canada, from Orange County, from Nebraska, from Oregon, Alaska, Pennsylvania, Guam, Orange, all over the place. So again, thank you all for joining us today. And we have a lot to get through in our didactic. So let's go ahead and have Dr. Hakimi go ahead and move us into the didactic. Let me go ahead and stop sharing so you can share your screen, Dr. Hakimi.
Thank you. All right.
Go ahead. Thank you.
Sure. The topic is practical approach to hypertension and lipid management, specifically for the geriatric population and in general, and it's not that different, and we'll go into the specifics of it. Before coming to UCI for cardiology fellowship, I did training in hypertension and lipid management at Cedars-Sinai at a center of excellence for hypertension, and learned a lot about managing blood pressure. and was part of a study. You may have heard of the LA barbershop study, where we would go to barbershops and measure clients' blood pressures and manage it there and treat it there, and use a lot of pharmacy help. And it was a bit of a social and also a medical mission and experiment to bring the care to the people, because barbershops are a place where it's much easier for folks to talk about their medical issues, and having medical personnel there and really relying on pharmacists to manage it was an experiment we wanted to see if would lead to clinical outcomes, and it did. It did significantly lower both outcomes cardiovascularly and also blood pressure numbers. I think it's a project that we're trying to develop and expand to other cities, but there seems to be a lot of benefit in reaching patients where they're most comfortable, and really highlights the importance of adherence in managing the blood pressures. As part of that, I became a member of the American Society of Hypertension Specialists. Believe it or not, there's a board exam for that, and it really changed my idea of chronic disease and blood pressure management. So I think in residency, we're all very excited about acute care and inpatient care, but there's really an art in dealing with chronic disease and managing blood pressure and lipids and really getting to know the patients. And I really appreciated that. Now I'm really interested in anything blood pressure related, specifically resistant hypertension, quote unquote. The objectives are guideline updates for blood pressure targets, effective approach to hypertension, white coat hypertension, masked hypertension, renovascular hypertension, treatment-resistant hypertension, and lipid therapy. I have no relevant financial disclosures, unfortunately, and we'll start with just how to measure blood pressure. Patient needs to be relaxed, sitting in a chair, supported back for about 5 minutes, empty bladder, to use a validated, calibrated blood pressure measurement device. Best blood pressure devices are soft cuff on the arm, not the wrist one, not hard cuffs. And in some of the recent trials, there's an advantage in measuring at least 2 times and really taking the last number, because there's this rising pattern where in the beginning when you measure blood pressure, it might be higher. The later numbers seem to be more accurate and representative of really what the true blood pressure is. And there's more reliance on out of the office blood pressure measurements, especially when you're starting a patient on a blood pressure regimen, or when you're still in the screening diagnostic phase, or when you want to see how you've progressed in blood pressure management for a patient. Ambulatory blood pressure monitors or home blood pressure monitors, ABPMs, ambulatory blood pressure monitors, are very, very helpful. We use quite a bit of that. It is now part of the guidelines, and reimbursement sometimes is an issue, but you're often able to get the reimbursement if there's a suspected white coat hypertension or masked hypertension for patients. I'll start with the JNC8, the guidelines that really changed the thresholds to treat and targets to treat to back in 2014. They had a much more relaxed targets for blood pressure and also thresholds to treat, especially in patients over the age of 60, in patients with comorbidities, diabetes, and CKD. And this wasn't really endorsed by a lot of the societies, and it was very, very almost too strictly evidence-based and not really realistic of the real world. And a lot of caution about minimizing potential harm, causing falls, acute kidney injury. But the benefit was really not seen. And out of the whole guideline, about 2 strong class A recommendations existed only. And they basically said in the general population, age 60 or older, initiate pharmacotherapy when it's 150 or higher for systolic, 90 or higher for diastolic, to a much higher target, which was really a change for us. And meanwhile, observational studies continue to demonstrate that elevated blood pressure and hypertension are associated with increased risk of CVD, ESRD, subclinical after and all-cause deaths. Then came the SPRINT trial, which tried to address the question of strict control versus lenient control, meaning should we leave the patients to a target of less than 140, or should we go even lower? The actual trial per design was less than 130, but they really, if you look at the numbers, they were very close to 120. Average was just in the early 120s. So they achieved the number difference. And there was such a significant reduction in cardiovascular mortality, heart failure, cardiovascular mortality, that they stopped the trial early because the benefit was seen, both in death and CVD outcomes. And you can see here the primary outcome was met, and also the CVD deaths. Individual ones did not meet, but as a composite outcome, they did meet. And then the study was stopped early, but there was an extension of the study to look at cerebrovascular outcomes, specifically risk of dementia or mild cognitive impairment. And they did see a benefit there. But this was also not continued long enough to have a conclusion about dementia, but there is a new SPRINT 2.0 by Dr. Williamson at Wake Forest. That's an ongoing study. So if you look at the risk in terms of falls, symptomatic orthostatic hypotension, or other SAEs, or hyponatremia, hypokalemia, acute kidney injury, they really they were more in the intensive treatment, but they weren't statistically significant. For what came out of the SPRINT trial and how it changed the guidelines was that the thresholds and the categories to call something high blood pressure versus hypertension really came down. And now normal is considered to be less than 120 over 80. Elevated is in the 120s for systolic, and stage 1 and 1 is in the 130s, and stage 2 is in the 140s. This is really in the guidelines, and it's still not acquired by a lot of practicing physicians, and it's still seen a lot that patients in the 130s are thought to be in the normal range. But it is an individual decision to make sure you're not dealing with somebody who's fragile and has other risk factors that may put them at risk for a symptomatic low blood pressure, but we should really target a lower number, and I'll go over that. The SPRINT trial had sick patients. They had, the average age was in the 70s, and in terms of inclusion criteria, was everybody over the age of 50. People had CKD, all other comorbidities except for diabetes, because diabetes was addressed in the ECHO trial prior to SPRINT. And that trial showed that there was a significant reduction in stroke with a blood pressure in the 120s, but not a statistically significant reduction in other cardiovascular events. But then the SPRINT trial had the significant reductions in the outcomes I mentioned, but did not include patients with diabetes. The ECHO trial, which had the diabetic patients, was basically a SPRINT trial specifically on diabetic patients. And it did show that there was a significant reduction in stroke, but not so much in the primary outcomes. The only concern that when you put the two together, the SPRINT trial and the ECHO trial, is that with diabetic patients, there's a risk of causing increased creatinine and a drop in the GFR in the intensive treatment groups. And there seems to be a J point with diabetic patients where there's a sweet spot between 130 and 140, and above which is bad, below which is also bad in terms of cardiovascular outcomes. But they do really well here. And if you go lower, it's not so much that the cardiovascular outcomes become significant, it's that the creatinine starts increasing and the GFR starts dropping. Whether that's clinically significant, it wasn't shown. nobody moved to end-stage renal disease. The GFR had dropped and the creatinine had risen. But the take-home point is that if you have a patient with high risk for cardiovascular events, targeting systolic blood pressure of less than 120 as compared with less than 140 did not reduce composite outcome of fatal and non-fatal major cardiovascular renal effects. So if you have a diabetic patient and the kidney function may not be normal, it's okay to try to keep them in the 130 to 140 range. But we should know that patients who had a lower blood pressure, specifically 120 or less, did have a major reduction in their risk of stroke, but not other cardiovascular effects. To protect the kidneys, I think patients may do better in the 130 to 140 range. Before I get into the medical therapy, who can benefit from non-pharmacological therapy? Patients with elevated blood pressure, so in the 120s, systolic with less than 80 diastolic. It's an appropriate first line for adults with stage 1 hypertension who have an estimated 10-year ASCVD of less than 10%. It's a calculation we can do based on their age and demographics and whether they have diabetes and also if they have hypertension. And DASH diet specifically can reduce the blood pressure by 11 systolic and 3 diastolic, high in vegetables and fruits, and low in fat and salt. Dietary potassium intake has been shown to improve blood pressure. It's really about the sodium-potassium balance, is to lower this sort of ratio with low sodium and high potassium. Alcohol intake, for people that are more than moderate alcohol drinkers, 3 or more, if they cut it, then it's shown to reduce their risk of their hypertension. It's shown to improve their hypertension. But in general, patients that drink 2 or less drinks a day, that benefit hasn't been shown. EECP, which is this external counterpulsation that really that dilates the periphery, the vasculature, and it's shown to acutely improve blood pressure, and it's thought that it's due to nitric oxide vasodilation and improving the FMD, the flow-mediated dilation. But that outcome, the acute outcome and improvement in blood pressure, has not been shown, has not really been studied for sustained effect and also for clinical prognostic benefit. And adherence and impact should be assessed within 3 to 6 months to see if this non-pharmacologic therapy is going to work for patients. In our experience, I was at a center for hypertension and had a lot of resistant hypertension and just bread and butter hypertension patients. And diet doesn't seem to affect blood pressure as much as it seems to affect the lipid panel. So we were more aggressive in as my mentor used to say, he was from Texas, and he always said, pull the trigger on drug therapy. And so we pulled a lot of triggers on drug therapy. So the JNC8, again, he used to say it's JNC8, and I would agree that the thresholds were way too relaxed, and outcomes were not good. There were more strokes and hypertension-related diseases that were seen. But to initiate drug therapy early is usually a good option for somebody who is considered to be hypertensive. Let's think of a real example. This is a real patient that we saw in clinic, 61-year-old woman with hypertension, severe hypertension and fatigue. And these are her clinic blood pressures. Every patient that would come in, we would measure bilateral, 3 different positions. You can imagine the clinic nurses must have really liked us and, to ask for all these measurements. But no, it was a great experience, and we were able to get a lot of information from measuring blood pressure so many times. And this lady had very elevated systolic and diastolic blood pressures. Looking at her exam, nothing remarkable really. The labs were significant for sodium 126, otherwise normal potassium and creatinine. This is glucose, sodium, chloride, potassium, bicarb, creatinine, BUN. So this is her initial treatment, and this is not an uncommon thing to see in the community. She was on losartan, high ZAR, which is losartan hydrochlorothiazide, 125 milligrams daily. She was on lisinopril, 40 milligrams daily. She was on atenolol, 50. She was on potassium supplements, BID, and Clonidine, BID, plus a PRN dose of Clonidine. And it's not a good regimen for many different reasons. Let's address them. First of all, she's on an ACE and an ARB. And that's a class 3. That's more harm than benefit. The only benefit you would get out of this is, and this is from a nephrologist that worked with us, is really you probably would have very little proteinuria because they do tend to decrease proteinuria, but at the risk of acute kidney injury and causing high potassium. And there's no reason that somebody should be on an ACE and an ARB. Let's talk about the diuretics that we commonly use. This lady was on a hydrochlorothiazide, and that's a very commonly used diuretic. It is not the best diuretic. It's not long-acting enough. It doesn't have good tolerance profile in terms of causing hyponatremia. And it has other reactions. There are cutaneous reactions that patients might get. There's a good discontinuation rate. And in somebody who is older, it's very common to see them present with hyponatremia. This lady's sodium was 126. There are alternative diuretics in general are very effective blood pressure medications, but I think we have options, and I think we should consider using other medications. Chlorothalidone is a good drug. It's very long acting. You can start at a lower dose. Yes, there are risks of potassium and magnesium drop, but it doesn't seem to cause as much hyponatremia. And if somebody is having a difficult to control blood pressure, it would be a more effective blood pressure medication. And dapamide is my favorite. This is not a very well advertised diuretic, but it's a very old medication, and it's very cheap, and it's very long acting. It's more of an indolent. And it's more of an indolent effect, not so much a very acute onset that patients might experience orthostasis with. But the reason hydrochlorothiazide is so commonly used is because it's just marketed really well. This is not marketed well. This is now used in more recent trials. This is a sort of an equivalency of doses. There is just about the risk of hyponatremia for patients, chlorothalidone versus hydrochlorothiazide. They're all very similar, less with chlorothalidone than hydrochlorothiazide. Now, first-line drug classes for hypertension, this is in 2019, is thiazide diuretics are still very commonly used, calcium channel blockers and renin-angiotensin blockers, ACEs or ARBs. Let's look at the discontinuation rate. Really bad with thiazides, intermediate for calcium channel blockers and ACE inhibitors, and best with ARBs. Cough is a common thing with ACE inhibitors, and they're mostly, with the exception of ramipril, they're not long acting. So if you see a patient on a BID dose of lisinopril, you shouldn't be surprised. It's really not an all-day effective medication. And one important thing to note is that not all ARBs are created equal. Rosartan is very commonly used. It's a very short-acting ARB. It's used in a lot of the trials, but some really good trials have used other ARBs, and they're quite effective. My favorites are irbesartan and telmisartan. And the rest of the ARBs, including olmesartan, are kind of like the dual, like the new oral anticoagulants. You sort of get used to one and you pick your favorite. But if you have the option where you practice, or depending on the patient's insurance, to use valsartan over losartan, or actually irbesartan or telmisartan over them, I would recommend that. They're longer acting. Telmisartan has excellent bioavailability. It's very lipophilic. It has effects on insulin resistance, good for sugar control too, actually. So these actually have much better blood pressure lowering and some other effects as well. Back to the patient. Likely her hyponatremia and low potassium was caused by the hydrochlorothiazide. The fact that she was on an ARB and an ACE increased her chances of AKI and hyperkalemia. Atenolol is not a good medicine. It's effective in lowering blood pressure and lowering the heart rate, but studies haven't really shown it to reduce risk of stroke. These are the studies. And atenolol is a renally cleared beta blocker. And it's not uncommon for us in cardiology to see patients presenting with heart blocks or significant bradycardias on atenolol because the patient had CKD or went into some sort of an AKI that then caused a clinically significant overdose of atenolol, because it is renally cleared. So in the geriatric population, I would try to stay away from atenolol if possible. Clonidine, also not a good medication, has a lot of problems. My mentor used to say Clonidine is the work of the devil. And that might be a little drastic, but let's talk about Clonidine briefly. It's not an ideal medication for first line, second line, or even third line antihypertensive. It should not be used as a PRN agent. It's common for us to see a patient in clinic with severe hypertension and give a dose of Clonidine. Numbers get better, everybody's happy, he goes home, and then he may come back with severe hypertension. I've seen patients with stroke because of the rebound effect of Clonidine. It is real. And this is especially exacerbated if there's a situation of unopposed alpha stimulation when beta blockers are on board. So alpha 1 is a vasoconstrictor, beta 2 is a vasodilator, and they work in somewhat opposite effects. They sort of control each other. If a patient is on a non-selective beta blocker, so blocking beta 1, blocking beta 2, and they're on a Clonidine, and they miss the dose of a Clonidine, and that's often true because Clonidine is often underdosed. Patients take it PRN, patients are on once a day, twice a day. It should, if it's used, it should be 3 or 4 times a day and with a meal. Anything less than that causes this risk of rebound hypertension. And so if a patient misses a dose of Clonidine or is just not, or just has a period during the day when they're not on Clonidine and they're fully beta blocked, then they have this unopposed sympathetic surge that's usually controlled with alpha 2, which the Clonidine controls. But when the Clonidine is not on board, they have this unregulated sympathetic surge that is not controlled by the beta 2, because beta 2 is blocked. So that sort of a control mechanism that beta 2 tries to counteract what alpha 1 does in terms of causing vasodilation, that alpha 1 causes vasoconstriction, that's not there. The beta 2 is blocked by the beta blocker, and the patient isn't just now having alpha 1 adrenergic surge. So patients on beta blockers are often at a higher risk of rebound hypertension with Clonidine. And tapering patients on Clonidine it takes some work, and patients should really keep it TID or QID and just decrease each dose, as opposed to going from TID to BID to once a day. It should be around the clock medicine, even as you're tapering it off. And I usually use a medication called guanfacine or Tenex. It's a centrally acting sympatholytic that kind of works like Clonidine, but it makes the tapering much more smooth, and patients don't have the sort of rebound hypertension as you're putting them on another medication. There's an overlap with Clonidine as you're tapering it off. I'm happy to talk about this more in the future about the use of 10x. Let me move to the next slide. Next thing is higher drug doses in JNC8 and previous randomized controlled trials versus low-dose combination therapy. I'm a huge fan of low-dose combination therapy. I'm happy to see that it's made it to the guidelines. And if you start a patient with stage 1 or stage 2 hypertension on low-dose combination therapy, you'll find that it's more effective without the side effects. If the approach is to go up on the dose of a single medicine and then go to the next medicine after you're maximized on one medicine, you're increasing the potential side effects and you're not as efficacious as if you had started with 2 medications, either a combo pill or just 2 different medications on low doses. That way the side effects are minimal, but you're really targeting the blood pressure from different pathways and you'll find that it's more efficacious. And as a class 1, initiation of antihypertensive therapy with 2 agents is recommended if you're over 20/10 from your target blood pressure. Combining drugs of different classes is 5 times more effective than in lowering blood pressure than doubling the dose of the one drug. Preferred regimen is the RAS inhibitors are very effective, diuretics are very effective, dihydropyridine calcium channel blockers are very effective. You can use any sort of a combination of these. The Legend trial really looked at the efficacy of blood pressure medications, and first, the most efficacious were diuretics. And then these 2, at the last was non-dihydropyridine calcium channel blockers, which are diltiazem and verapamil. Dihydropyridine calcium channel blockers are more vasculoselective. So this is amlodipine or Norvasc or nifedipine. Non-dihydropyridine calcium channel blockers are more myocardial selective and tend to reduce the heart rate more. These are verapamil or diltiazem. Think of V for verapamil, D for diltiazem, like Valentine's Day. It works on the heart, but it's not a good blood pressure medication. But the dihydropyridines, amlodipine and nifedipine are much more of a peripheral vascular resistance effect and blood pressure lowering medicines that are better. The beta blockers, the evidence is weaker for them, except if a patient has indications like heart failure, systolic dysfunction, cardiomyopathy, post-MI patient, AF, angina, then it's a good idea to use beta blocker, which they need and they're indicated for, and use one that also helps with their blood pressure. Vasodilating beta blockers such as notalol and carvedilol are great blood pressure medications. And diuretics, as we talked about, there's growing interest in mineralocorticoid receptor antagonists. So this is spironolactone or eplerenone. There's a new medicine coming down the pipeline called finerenone. That's a long-acting medication that's very selective, like eplerenone, doesn't cause the painful gynecomastia that spironolactone causes. But they're often effective. When you have a patient with severe hypertension, there's often a degree of subclinical hyperadrenergic aldosterone level that's high, and using the spironolactone or eplerenone seems to be very effective in those patients. Let's go to the next slide. I do recommend, if you have a patient with stage 1, if you're more comfortable with stage 2, to try to use a combination therapy and then move on to other medications. Ambulatory blood pressure monitor is very helpful. It's a class 1 for starting medications and for titrating the medications. It's helpful if you can get it approved, and depends on the institution and also indication for patients. Just a few words about ambulatory blood pressure monitors. They provide a very good method, better method at predicting long-term cardiovascular outcomes than office numbers do. Higher daytime from ambulatory is associated with an increased risk of CVD and all-cause mortality independent of clinic measured blood pressure. It confirms the diagnosis of hypertension. You can rule out white coat effect, white coat hypertension, and assesses the effects of treatment, improves compliance. Nocturnal blood pressure is really important, and you can get that through ambulatory blood pressure monitor. There's a phenomenon called nocturnal dipping, where it's healthy to drop your systolic blood pressure by over 10% when you're sleeping. And people who don't, we call them non-dippers, they have an increased risk in their cardiovascular profile. And it's a very, very important subject in blood pressure management to really make sure that the nighttime blood pressure is well controlled. Older patients with CKD, African Americans, they're more likely to have a non-dipping pattern. It's definitely a target to go after if you can. This is more of a correlate with CV death than the other blood pressure measurements for these patients. White coat effect is a rise in blood pressure in the medical environment, regardless of ABPM or use of, so whether or not the patient has hypertension or not, if there's a rise in blood pressure in the medical environment, that's white coat effect. White coat hypertension is if they are hypertensive, but then ambulatory is normal. MAST is the opposite. And then both incidents of white coat hypertension and the size of white coat effect increase with aging. In contrast to white coat hypertension, MAST hypertension is associated with CVD and all-cause mortality risk. And white coat hypertension cannot reliably be diagnosed in routine office evaluation. I'll go through this relatively quickly, just shows the normal sleep versus awake patterns. This is a trial that's worth mentioning. They studied patients that took their blood pressure medications during the day, in the morning, and then they switched them to take them at night. And that's the only intervention they did. No change in medications, nothing else was changed. They were, this was very, very controlled study. They made sure compliance is excellent. They measured urine levels. Follow-up was quite long. They used ambulatory blood pressure monitors. Multi-center randomized Spanish study. The only intervention was nighttime versus daytime. And the outcome, they looked at a lot of things, and there was such a significant difference in outcome, almost unbelievable. And this was controversial in the hypertension community because for a primary prevention study, so patients that didn't necessarily have high risks for CVD, where it would be unmasked, and it's easier to study CVD outcomes in patients that are high risk for CVD. But if it's a primary prevention trial, that's not placebo controlled. So it wasn't intervention versus placebo. It was intervention versus same intervention, but just different time of taking the blood pressure medication. For that kind of a study to have such a drastic improvement in every subgroup, that's impressive. The relative risk reduction was somewhere in the 40%. But none of the criticisms really stood for this study, and it was quite impressive. And it makes one think of the importance of nocturnal blood pressure control and really treating this early riser in the blood pressure that happens with cortisol surge if you take the medications at night. So routine ingestion by hypertensive patients in 1 or 2 blood pressure medications at night, as opposed to waking hours, resulted in improved ambulatory blood pressure control. So their nighttime blood pressure was lower for patients that took it at night, but overall daytime blood pressure was not statistically significant in terms of their difference, which is important. I mean, if those patients didn't have the ambulatory blood pressure monitor, they would still have the same morning blood pressure. But it shows you the importance of nighttime blood pressure, and that something is really to go after at night. Larger difference in mortality between treatment groups ever reported in a blood pressure lowering trial. Even more striking for primary prevention trial that's non-placebo control. Only modest difference in morning blood pressure between the 2 groups. What is treatment-resistant hypertension? It's defined as a blood pressure that remains above goal despite concurrent use of 3 antihypertensive agents of 3 different classes, one of which should be a diuretic. That's treatment-resistant hypertension. But it's a lot more rare than we think, because there is a lot of factors that might make someone appear like they have treatment-resistant hypertension. You have to rule out these other factors: lifestyle, diets, other medications, pain medications, secondary causes, endocrinopathies. Compliance is a big issue, big issue, which was also a major criticism of some of these negative trials, like the when they tried to go after their renal artery denervation. There are many drugs that increase patients' blood pressures. We have to be cognizant of those. Secondary hypertension is elevated blood pressure that results from underlying, often correctable cause. It's quite common, actually. I spend quite a bit of time screening patients for primary aldosteronism. It's a really rewarding experience to diagnose primary aldo and then treat it, because you can cure these patients of their blood pressure medications, and also the significant amount of potassium supplements that they might be taking. When do you suspect primary aldosteronism? When they have significant high blood pressure, and especially diastolic is being high. If it's resistant on different medications, if the onset is at a young age, they have LVH at a young age. Hypokalemia is a big risk factor. It can be a little bit cloudy when patients are on diuretics, and you wonder if it's the diuretic effect that's causing the hypokalemia, or could there be a degree of primary aldosteronism? The trick there is that usually diuretics cause low potassium and low sodium, but patients with primary aldo, they're not hypervolemic. They're actually, their sodium level is either normal or high, actually. And then they have alkalemia as well, so their bicarb is usually elevated. I'll go through this relatively quickly here. I recommend that we do more screening. Dr. Williams, who authors the primary aldo guidelines out of Mayo, he always talks about how primary aldo should be more advertised and thought about. There shouldn't be any fear of confounders from medication that patients might be on. If somebody has low potassium, their receptor is not blocked enough, so they're likely going to screen positive if they have primary aldosteronism. And it's good to get a plasma renin activity and an aldo level. And you should have positive for both. The ratio is not really important. Guidelines, then the guidelines from 2017 just have these criteria to be met, not so much the ratio. Renovascular hypertension, we may often think about patients as having hypertension due to renovascular stenosis. If it's a young patient, we think about fibromuscular dysplasia, and it's more of a spectrum. They might have characteristic stenoses of vessels in other places. With atherosclerotic, for older people, we usually think about renovascular hypertension, and it would really be an indication to intervene, either open them up with a balloon or stent if they have like recurrent flash pulmonary edema, or they have renal function that's weak and we want to preserve that. Or otherwise, medical therapy is still recommended. This is a fibromuscular dysplasia. They have this picture of beads. It's more diffused or central in the renal artery versus atherosclerotic, which tends to be more proximal at the renal artery and focal. Medical therapy is really still great, class 1 indication. I recommend thinking about mineralocorticoid antagonists, spironolactone or eplerenone, if the patient is on so many medications. That usually really helps reduce their need for other medications. So in the hands of an experienced clinician willing to systematically evaluate and treat their patients, treatment-resistant hypertension is a relatively rare condition. This is from Dr. Williams. I'm sorry if I've bored you. I'll stop for a second to see if there's any questions before I go to a cholesterol topic. One last thing about hypertension. is this was a very large meta-analysis that was presented at the European Society of Cardiology, looked at many different, I think 48 randomized controlled trials, 350,000 patients, good quality studies. And they found that no matter where you start with your blood pressure, even the classic 120/80, if you lower it, your risk of cardiovascular disease in terms of outcomes, this is a composite stroke, MI, non-fatal MI, heart failure, all of those, they go down. And it makes one think of really what is hypertension. And the comments from the authors was that we should really think of hypertension as a risk modifier, no matter what your comorbidities are. Yes, with diabetic patients, you want to be careful about preserving their kidney function. But in general, lower seems to be better. And no matter what your comorbidities are, and no matter what your blood pressure is, if you can lower it and the patient can tolerate it, you are lowering their cardiovascular risks. And I think that is really a different way of thinking about high blood pressure in today's era. And all the new studies are really supporting that lower seems to be better. Ambulatory monitors are helpful when possible. Low dose combination therapy using potent long-acting agents. Just a word about this. There's a lot of with medications and are asked to measure their blood pressure at home and take an additional dose if it's high or skip a dose if it's low. These directions may not be very helpful. It's not fair to the patient. If we can choose medications that are truly long-acting and potent, patients should not have fluctuations in their daily blood pressures, at least not fluctuations that are symptomatic or clinically meaningful. Unless you're a patient with end-stage renal disease where volume changes during dialysis versus non-dialysis days can really change your blood pressure. If you're not end-stage renal, if you have blood pressure that's managed with long-acting potent medications, you shouldn't really have those fluctuations. And it's often they are okay to be on a stable dose of medications and not have to really change or manage it themselves at home. And just things to recognize with secondary hypertension and white coat effect on white coat hypertension, and consider nighttime dosing. I have high blood pressure myself, and I take my medications at night, but it's one study, and I think I just don't see a risk in taking it at night, and I see potential benefits. Cholesterol guidelines. When it comes to geriatric patients, it's important to think of statins and whether that if they're still beneficial or they're not beneficial. At least we know from the PROSPER trial that they are safe and they are effective in terms of lowering risks. This is significant changes in risk profile for patients that were on pravastatin 40 a day, and that's a good age group for us. And in terms of safety effect, there was an increased risk for all cancers, but it wasn't, when they did the sort of the post hoc analyses of cancers and their pre-study risk, it wasn't found to be statistically significant. The major safety concern was the increased use of any cancer in the pravastatin group, which was not confirmed in a meta-analysis afterwards. This is the recommendation from the 2018 guidelines: is patients 75 age or above that have a LDL level of 70 to 189, class 2B, which means it's a relatively weak evidence. The benefit is either the same or greater than the risk. So it really becomes a discussion with the patient and their family to lower their cholesterol to a lower target than 70. And it's helpful to, here it says that if they're, if there's any question of, if there's any reluctance or you need help with making the decision, it might be helpful to get a coronary artery calcium score and then decide based on that. We all have a higher coronary artery calcium score, but they do stratify it based on the sort of age and race-based groups. And if you fall in the above 75 percentile for your age group, then initiating statin therapy is recommended. So I think in general, okay, I will stop here. I think I might have gone over time. What time is it? Oh,
Dr. Hakimi, you can close out really quickly if you need to.
And this is ASCVD plus calculator that we often use to estimate patients' risk to start them on statin, but doesn't really apply to geriatrics. It goes up to 70, 79. So using a combination of ASCVD risk factors, if it's high, and also coronary artery calcium score, I think it's an individual decision to make for the geriatric patient to start them on a statin or not. And that's it. I'm sorry to go over time, but I will.
No problem, Dr. Hakimi. We have a few questions in the chat. If you can take a look at them and answer them via the chat. Thank you so much for that wonderful didactic.